All right, y'all, we're gonna go ahead and get started. We do want to end on time, particularly if this is your last session of the day, for everybody to get back, or if you're staying tonight for dinner. And some of us are meeting in the Bourbon Bar upstairs afterwards for a couple drinks. So sign in. I think I'm going to, yeah, there it is. There's the agenda. So just want to say welcome to everybody. My name is Michelle Wallace. I am Chief Nurse at Grady Health System. I've only been in that role for about 15 months. My background is ER trauma and critical care. I've been doing that for almost 3 decades. And actually been a part of the commission. I've been a commission member for almost 3 years, but I actually went to the very first meeting of GTC back in 2008, 2009, when this first started. Been a part of trauma in Georgia for a very long time. So just thankful for the opportunity for us to be here. Gabby, I believe we have a forum. We have enough people. Yep, good, awesome. All right, so you should have received your minutes from our October meeting. So we need approval of those unless there's somebody that has to comment. Can I get?
Motion to approve. Second.
Perfect, thank you. Anybody opposed? All right, excellent. So the rest of the agenda today, Liz is going to come up and give a trauma commission update. I'm going to briefly touch on a couple of finance things that Regina and team are working on. And then we're going to talk about the trauma transfer that's in the GCC that's there. It's actually been used a few times. And then talk about some next steps for this group and really what works for you, right? You're administrators and we want your time to be valuable and used well. I know it's hard to be away from your facilities, and so we want to make sure that whatever we're doing is adding value to not just you, but to your organization. So we'll talk about that. So Liz?
There may be a few new folks in the room. I'm Liz Atkins. I serve as the executive director for the Trauma Commission. So for the benefits, I know a lot of you cannot be here tomorrow for the commission meeting. So just a few critical updates for some that were in the level 3, level 4 meetings. Some of this might be a little redundant. We talked about this morning that the State Office of Rural Health is about to release another round of rural stabilization grants. So it's very important for our level 3, level 4 centers. There's going to be about $7 million released in 8 grants. There's 55 hospitals that qualify, and unfortunately, they didn't ask for my input about how to do this, but we could have spread the 7 million around a little bit more efficiently, but that's what it is. So I just want to make sure that there's about 6 of our trauma centers on that list, and certainly it'd be nice to make sure that we can support them however we can, and we're certainly going to do that. So I wanted to make that known. We're happy to help you in any way, shape, or form, provide some financial or whatever you need for the application to be successful. And then many of you, were either part of the virtual participation for our ACS trauma system consultative and rural focused visit. And thank you for that if you came or supported your folks at your center for coming. The ACS was very complimentary about the stakeholder engagement that we have. We certainly can't do that without all of you. And we need all of you. We need your input because, we're about to get 120 some odd page report dropped in our lap, and we can't fix this alone. So we need you to tell us what works and what doesn't work, really, and help us kind of work through some of the barriers. So we should be getting that report 1st of April on or about. So we'll push that out to everybody as well as we post it on our website. And then we'll have to, one of the things Michelle, the level 3, level 4 group talked about was what does planning look like for, kind of talking through some of those issues. And so we need to start really thinking about that now, because I know everybody's time is limited. And these meetings are already so crammed from 7 a.m. until 5 p.m. So it's really hard to get additional time in. So, so we want to make sure that we have the right people, again, stakeholders at the table to inform a lot of the solutions. The other thing that we actually did in November, that some of you who were in the November commission meeting, the Pennsylvania Trauma Foundation did a series of consultative visits for our level 4 centers because the ACS does not have a process for that. And we found a lot of opportunity. And so we're working on education for level 3 or for level 4s, excuse me, and also mentorship programs. So don't be surprised if coming to a PVP, a performance-based pay criteria to you soon will be for 1s and 2s to serve in mentor roles for the level 4s. Okay, they don't necessarily need level 1s and 2s to come in and say, this is how we do it in the level 1 and 2, but they do need some guidance. And certainly what we found out is they need feedback on the transfer cases that they're sending to you. Because by and large, and that's a fixable problem, right? We own that. We can give them feedback on those patients. So, and if you can't be here tomorrow, we will post the presentation. We're going to have a well-known healthcare economist, Etienne Kroc, who we worked with. We worked with Dr. Kroc for a long time now. We published back in 2014. Was that our first analysis?
So long ago.
I know, how's it been 10 years? I've grown a lot of gray hairs over that, but we did our first 10-year analysis of the trauma system in terms of where are our patients going. And we learned a lot from that study. It was very valuable because it utilized the discharge data set. So it didn't rely on registry data, which we know is only accessible through our trauma centers. So the discharge data set allows us to look across Georgia. Where are the trauma patients being seen? What does the distribution look like in terms of injury severity across age groups? It was phenomenal. He's even broken it down into RTEC regions, so EMS regions. So the subsequent 10-year, 2013 to 22, will be presented tomorrow. And we were a little delayed on our replication of that because of the transition from ICD-9 to ICD-10, because that uses a crosswalk to determine injury severity, because really only the trauma registry and AIS coding allows us to know truly how severe a patient is. So that's a little bit more in the weeds than this group really wants to get, but you have to understand that we need to figure out like sick and not sick, for lack of better terms. So we'll be hearing about that tomorrow, and hopefully that will help us identify, potentially some more candidate hospitals, particularly in region 8 and 9, where we know that we are really grossly underserved with respect to trauma care. So those are kind of the big ticket items. The other thing I will mention is that we have a lot of centers, and a lot of you have grabbed me in the hall, that are designated but not funded. Our funding stream, while strong, remains constant, and we don't have a lot of extra money to throw at centers. So you're all here, and I just want to make you all aware that we're trying to work up proposals, and Dr. Medeiros, who's our GTC treasurer, chairs our budget committee, and we're working up different models for 24. What does that look like? Now we do have one less level 1 in Atlanta. So with the potential distribution of that money across all of the trauma centers, as well as bumping up the base readiness funding for level 3s and level 4s. If you weren't aware, level 4s historically only got $12,000 a year in trauma center readiness. I'm not sure I would participate if I'm a CEO. I'm gonna write it one right now. He's looking at me saying, you're right, that's crazy. It's just hard. It's been the same amount of money, while the 1s and 2s flux depending on how much money is generated by super speeder. The 3s and 4s were funded at what we call stipend levels. So their funding never changed. So we will increase the level 4s. We'll add an additional 25,000 on top of the 12 and 75,000. I think I said 50 early this morning, but it's actually 75,000 for the level 3s. And I'm just going to be honest, and Regina will say the same thing. This was kind of a shot in the dark. We didn't really know how much to increase it by, because if you look at the data from our trauma center readiness costs, we know that level 1s and 2s are funded at a level that's roughly about 7 cents on the dollar to what it costs them to what they get. Based on the data we have, that essentially puts 3s and 4s over that 7 cents on the dollar, but we don't feel like we have really good data to show what it really costs you to provide good trauma care in your facilities Once folks go on to be verified, we think we'll have a little bit better accurate accounting of what the true cost is to maintain verification. So that is the huge news. People always want to have money. So that is going to be on the table for redistribution, as well as our firework fund revenue, which our budget process are changing slightly due to the trauma trust fund that was established, not last legislative session, but actually the one before that. It took time when they finally dedicated our super speeder funds and our firework funds to set up that trust fund. Now the money goes directly to it. So we're in a much better position there, but as Dr. Ashley will tell you, we really need closer to $80 to $100 million to fund this system adequately. We haven't done anything around transportation, and that's one of our charges. So we don't have enough money to touch that. And so there's that fine balance, and you're all the right ones in the room because you run the programs. You're financially responsible for your program. We don't want to thin the pool out of the funds too much, but there is definitely a need to recruit centers and bring on these centers that are making the effort, going out there, getting verified. And so it's a delicate balance. So I think that's about it, but I'm happy to take any questions. And Regina, anything to add to that?
No, I don't think so. I think the one thing that you hit on was the fact that even though we did do the readiness cost survey for 3s and 4s, and it was something that hadn't been done and gave us sort of a baseline, we felt strongly when we got the information, and then with the PTSF consult visit, that it woefully underrepresented what the true cost is to do all of the things that are required to be done. And so we didn't want to use that as a baseline to determine how much to provide. We wanted to be able to provide above that so that we can help all the 3s and 4s meet the expectations and then move forward with the verifications and the standards. And then we'll have a better idea of what the true cost will be. She covered that pretty well.
We also had very much an underappreciation for what your software maintenance costs were relative to the registry, particularly for 3s and 4s, again, because your funding was so low. So like a typical 4 got $2,300, I think, for registry, but your registry probably cost you $8,000. So now you're really dwindling your readiness funds. And I'm saying this in this big group because I think it's helpful for the 1s and 2s to really understand where we have to shift funding, because these things aren't getting cheaper. The registry is really the backbone, drives everything we do. So if we don't have good quality data and invest in the 3s and 4s to make sure they can get good data, then we can't drive improvements to our system. And we did invest 2 AFYs ago, 1.3 million in this Arbormetrics risk adjusted benchmarking program, which will be a little bit better than what the 1s, 2s, and 3s participate in now with ACS TQuip, because it should be a little bit more real time. It'll be a little bit more real-time snapshot, and there'll be a lot of tools in it for your folks to access, because PI is hard enough, and particularly if you're in the rural facilities, it takes a lot of effort. The 1s and 2s tend to be a little bit better situation with that in terms of having staff to support all that work, but any additional tools we can give you to be successful, be able to look at some of your opportunities and know that you're actually making a difference will really help with less effort. All right, thank you.
Thanks, Liz. Great updates. So I want to talk a little bit about the trauma transfer diversion. So in December, we had a number of educational opportunities. We had 11 centers actually participate in that education that Lori did around the trauma transfer. So the purpose of that, where that came from, was for those that utilize the GCC board, and that actually started pre-COVID when Grady had their flood. But prior to that, there was this old Georgia 911 website that was used, that was manned by a volunteer who literally had no, he was just a nice guy helping us out, literally in his basement. He said he had this little setup in his basement. So from that, there were these traditional definitions of diversion, saturation, which, by the way, saturation is not a legal term. It's one we created in Georgia, and then everybody threw their version of saturation on that. So I don't know how many people are familiar with those pieces, but I'm seeing all the recognition and some nods of heads in the room. So there's lots of different definitions, 18 of them. We in this room are not going to dwindle those down today, or even actually we won't be the main group doing that. But what we needed to do from a trauma perspective was be able to have a way for you as the trauma center to be able to communicate when, yes, I can still take ground traffic or I can take air traffic, but I cannot take transfers. So what we found, particularly during COVID, is when it got extremely bad, is that smaller hospitals were trying to send patients and everybody denied. For days and hours, I'm looking at some of my partners around the room that I've talked to, and for days at a time, and these patients sat critically ill because all of us, the big center, said, sorry, we're not taking anybody. Well, reality is there's probably always one of us that has some capability and could do that, but we don't communicate. We don't communicate effectively at all. We have the ability to do that, and we're going to have to put some structure around that very quickly, but we weren't. So we created this trauma transfer diversion for trauma centers who cannot take transfers, but can actually still take ground traffic, because we didn't want to use total diversion or trauma diversion, because then everybody thinks, oh, they can't take anything, and they're not going to call them. So we created it, 11 centers, we had multiple education events. Right after Thanksgiving, it went live early December. It's been used 3 times already, not a lot, but it's been used. So excited for that. But when it comes down to this, and I'll give a GCC update in just a second, you know, the tool is there. It can be used. It can be used very effectively. But we have to use it. Like, we have to operationally make it a part of what we do. In Metro Atlanta, we do it very well. It is a part of our life. It is what kind of runs the show. But from a GCC perspective, the goal for that is not to replicate what's in Metro Atlanta. It's not going to happen. It doesn't apply to South Georgia, to severe North Georgia. It just doesn't apply like it does there. So what it does apply to is transfers and being able to accept patients. So I do have Lori here with us today. I'm not putting her on the spot. She doesn't have anything to speak. She's just here as a reference. But if you have questions about that, I know a number of you all went through the training. If you want to make sure you have the right people that are still signed up to have access and to create that, she is here as a resource to be able to get you in the right direction and help fix that. Does anybody have any questions about the trauma transfer option? What I have asked her to do, just because I know, well, let's just, at the end of the day, let's be transparent. All of us in this room that are administrators, we don't have one hat. We probably have 12 to 18, and on any given day, a whole bunch more. So what I've asked her to do, because my resource has always been, particularly as an administrator, when I need something, is I go to my trauma program director. They know everything. And so what she's going to do is she's going to send out the education that they did online to the TPM director group, and then that way they have it. It can ensure that if you all need it or others need it in your organization, that it will be available. It's a pretty constant group. This group fluxes a little bit. There isn't, you know, we have some changes, which is great, but we want to make sure that everybody has those resources.
I have a quick question.
Yes,
So,
absolutely.
yes, welcome to Metro Atlanta. Yes, this was our training last year, wasn't it? So our organization, we absolutely got into that space, right? We can actually go on diversion and whatever, although both of our facilities are on diversion, no one's on diversion, right? So it's a needs facility. And we struggled greatly because we're being overwhelmed by transfers in. Our legal department because we had a lot of issues with this, our legal department was very conservative with pulling any triggers on stopping that based on EMTALA. So how does this fit, that designation fit, as it relates to EMTALA violations?
So one, EMTALA does not apply to transfers. So EMTALA is ED to ED,
Yeah.
but if your ED is able to state that you, no, coming back up, each legal department has to make their own decisions. Brady's is very comfortable saying, if we're full, we're full. Like, we can't take it anymore. Now, we don't use trauma. We don't go into total diversion anymore. I mean, with trauma. But the first year legal department has to be comfortable, and when you all can use that. There's a law there is a general consensus, but as everybody in the room knows, every lawyer has their own version of what that is and what their comfort level is. So they are gonna have to make that decision. But secondly, when it comes to, and having been through probably a dozen EMTALA visits over my lifespan of being an ED director, as long as you have the documentation that you're full, you do have the right to say we can't take any. You don't, particularly transfers. Now, ground traffic, when they get within that 250 yards, a whole other story. But transfers, if you can, and that's what I've had to do in the past, is I'm like, here's my OR capacity, we're running for, 2 or 3 rooms, here's our order numbers. We could not safely care for that patient. But again, that's your legal department is gonna have to, whatever they're comfortable with, they're gonna have to set those guidelines for that. And particularly for trauma centers, for those that you're the only thing, or for pediatrics, you're the only thing, it makes it really hard to be in that space, because you don't want to say no from a clinical ethics perspective, but operationally bringing one more patient in. I mean, we had 88 orders in the ED this morning, so they're dying. We couldn't take one more, so it's not even physically possible. But it's, again, it goes back to the individual center's legal departments. It's a great question, because it always comes up.
Yeah.
Always. Any other questions around trauma transfer? All right, so a little update. Lori presented the Georgia Coordinating Center at the November meeting and had the opportunity to kind of share with the commission what actually it was, what the purpose of it was. So I'm not going to go through all of that, but a few things have occurred since then. I sent to everybody that was on the listserv at the time. I sent the PowerPoint from the ACS visit. So hopefully you all received that. I sent it, I think, like January, right after 16th or 17th, I sent it to all the administrators group. So you all can kind of see what that conversation was. There was a lot of conversation about transfers with the ACS. They had lots of conversations and lots of thoughts about that. We came back from there, had some conversations with our DPH partners and our EMS partners and GHA. And, originally we wanted this group in here to help with throughput diversion. There's 34 trauma centers, but there's over 100 hospitals in the state. And so this group really isn't going to be in a great place to make those decisions. Once again, it's us. We don't want to be telling people what they need to do. It's not, they won't do it. What this group can do, one, is be a liaison. So the GCC, we had our first meeting already about 6 weeks ago. We are bringing in most likely an outside consultant who is going to help us with scope of operations, as well as oversight for that committee. So just for awareness standpoint, the GCC operationally has always been managed per se through the Grady arm there with Lorraine Emergency Management. But management has been a little bit different. And so kind of bringing it back, wiping the slate clean, creating a new board for that. When we do that, one of the very first things we're going to do is decrease the definitions that are there, because it doesn't mean anything. It really doesn't. And with 18 of them, but not only decreasing the definitions, I will tell you, having the ears to the ground regularly with the GCC and the radio, and not just from my hospital, but because of our oversight with that, we put EMS in a very bad spot some days, and that's not okay here. So we really need to delineate what those definitions are, and we need to be able to clearly decide when we go on that. Need docs is what was used when we rolled out GCC, and that was actually a Metro Atlanta decision. It is not the best tool, but it is a validated tool, and you can look at trends. But there isn't a lot of other options out there, so we do use the NEDOCs, but we really need to help understand what those definitions are. Now, for this group, I think the one big ask is if you're not using the GCC, even just daily, if it doesn't impact you like it does those in Metro Atlanta, at least begin to get familiar with putting your information in there so that you have options, you know what's going on, you have the ability to understand what the state looks like, literally the state looks like. And I say that because in about 30 days, they're working on it now, the build, we are moving to a new platform called Image Trend. And one of the questions and asks of this, well, the administrators group, but of the need within the trauma system is communication. And so we will be able to build groups very quickly. Actually, I've already have two I've asked her to build for communication. So if you're putting your accurate information in the GCC board and Regina, Augusta decides to go on total diversion, we can send that message to the set group. So we can communicate that out to whoever you want in your facility to know that. But you need to be able to, we have to use the board, right? We have to use it so that there's consistency and everybody knows what that information is. So that is the first ask, is for you all to make sure that you're using the board and effectively. And because at the end of the day, we're talking about just trauma transfers, but an example, when the hurricanes hit the Bahamas and they activated Region 4 within FEMA, right? Yeah, I always get that. I have to make sure I get that straight. You know, a lot of us receive patients. Well, it was a lot of phone calls. And they very easily could have just gone to the GCC and said, okay, this hospital, you know, in South Georgia has capacity. This hospital in North Georgia has capacity. On the coast has capacity. And it didn't. It took a lot of time doing that. So one, access so that we know from a transport perspective, and then so we have the ability to communicate effectively in time of need. The second thing is communication regions. So like I tell our frontline nurses, I'm an ER trauma nurse by background. I can make a decision in 2.2 seconds flat, but you don't always want me making those decisions. So we need this group to provide feedback on what that communication region would look like. Who you see within your network that you have constant communication with. And we won't make the final decision. We'll take it to actually Dr. Ashley, Dr. Dunn, and the other surgeons and other folks that are at the front line in those areas. But if you were to want to know what's going on in your region, who's in that market? And it can't be, we looked at EMS regions, but yeah, we all cross like three, I mean, they're all over the place. You get patients from everywhere. So I will be sending out an email to get your feedback on who within your region you would want to know. We'll put it in consensus, we'll have it in a spreadsheet, and then just be able to marry that out to know who you would want to receive information. If Grady's going on total diversion, who wants to know that Grady's on total diversion? And who in your facility is going to want to know that we went on total diversion? Does that make sense? Yeah. Okay. All right, and so we've got 20 minutes left. Just want to open it up to hear from the group. When we met last year here, well, I just do a finance update. I totally skipped it. Let me jump back. I apologize.
You hit the touchpad, it should come back up.
Ah, there we go. I jumped right into the phone transfer. So Regina and team are leading a work group, and she can definitely jump in and correct me on anything that I say here. She's leading it. We have a couple of finance folks. I know we have our VP of Finance, Grady, that's participating. And so they're working on a couple of different deliverables. One, education and training. So for those of you that were here last year, we had the finance workshop. And every time I hear something new in finance, or every time I hear finance or something around it, I learn something new. There's always something different. So they're working on what are your needs? What does that look like? I think you're working on a dashboard or getting that direction to get a dashboard. So that's a big one, just because there's Regina and team, but then Gina from Gwinnett found many years ago was there was a complete disconnect in what finance is focusing on and what our capabilities were for charging, and actually netted quite a bit of dollars. Just because they made a couple of changes within their billing system and making sure that you're capturing right charges. So that's a big component within, for this group in particular, you're all administrators, no matter what your role is. And it's something that I know all of us are keenly like watching every day. 65% of hospitals in the United States are losing money this year, and many others in Georgia are as well. So it's really important to make sure that we're getting every ounce and every dime that we can around finance. The second piece is, and actually ties into Liz's conversation, is around the funding that we get and how do we use it. So one, how do we use the funding that we receive from the commission? There are things that we are supposed to use it for. Well, let's be honest, I won't ask you to show of hands in the room, but how many of you have your dollars go to the black hole of the bottom line? Ours do. That's right where it goes. Now, granted, it's a drop in the hat compared to cost and what we spend, but where does that money go? And I know, so I will share with you, we did that with trauma, but with burn, we actually had a different conversation, and we were actually said, no, here's dollars that we have to do things with burn training, there's a number of different things, and we were actually able to pull that out and use it for what it was used for, which is the intent and the funding that we get through the commission. So that's a big piece, that's one of their deliverables, and as she'll tell you, they kind of build upon each other, the education and training, what are you using it for? I will ask you though, if you think about dollars and finance and hospital operations, I know it was $10 million a number of years ago for a level 1 to have readiness. If you just throw in even just staff increases in salaries, I guarantee you it's way more than $10 million. I know everybody's doing big adjustments. And so those are things that we have to take into consideration. And the third piece is tying into actually what Liz started with, is around funding, who gives what. So any questions about that, or Regina, what did I forget? Try to make sure I covered all your bullet points.
No, you did, thank
Okay.
you. No, we covered everything, pretty much, yep.
All right, so open floor, open forum. You know, we're all busy and I don't want to waste your time. Just be honest. We want to add value, right? We want to know what matters to you and what conversations you want to have.
I'll ask a question, Michelle, and follow up to the finance update. One of the reasons why we're doing this is because we have to assure the legislators that the commission's funds going to centers are our payers of last resort, like all other government entity and funding. And so it's our responsibility to help ensure that all of the centers participating and receiving funds are maximizing their appropriate opportunities for coding and billing for trauma. And I know from the workshop we did last year, there were several survey components to that around activation fees and accommodation fees and so forth, that a lot of centers were not charging those. So I'd like to put out, you can send an email to Michelle, I'm welcome to entertain some brainstorming ideas, but in order for us to be really effective, I think we need to know where the gap is. It's hard for our work group to know all of you and all of your centers' gaps and needs. We come in here and we talk, we have some general ideas of what we think people need, but to really make it meaningful, I think we probably need to hear from you to say, well, our center is really struggling, or I don't even know what you're talking about. I reached out to finance, and we started in our institution very simple, looking to see if patients were even coded correctly on the electronic UV form. And Marianne can attest, we get these every day. This is not a trauma. But finances and billing and accounting have really gotten excited about it, and they're following up, and the improvement over the number of patients who are put as a type 1, which is emergency, versus the type 5, which is trauma, is tremendous. And then, leaving your G code on your bill regardless, you can take it off the credit if you don't have critical care, but that's how you increase your reimbursements down the line. So getting people to understand that, or even starting what she was referring to in regards to the dashboard, was we want to help people create a finance dashboard where you're looking at these things, where the administrative group works with the trauma program group and the finance group to say, just like you do PI for clinical care, you do PI for finance. Where are opportunities for improvement, and then how can we help everybody else to rise to the same level? So, but like I said, we need your feedback, and we need to know sort of where the gaps are and what educational needs are that we can build upon from last year's workshop, which was probably like drinking from a fire hose for some people.
That was a 2-day workshop condensed
Into
an
an hour and a half.
Yes, 2 hours. It was a lot of information. And if the group wants some kind of education like that, we can do it. We just do need a lead time on that because, we have to, particularly because that came through TCAA. And it's like one of their package courses. They're willing to condense them like she did last year and make it like part 2 a little bit more advanced, but that's something that they have to from the full workshop. So it takes a minute to get that. And then we have to put sort of placeholder in to get that.
or if it'd be helpful, they have a finance manual, would it be helpful to break down components into modules that people could kind of pick a la carte, where some people may be at different levels of understanding, but we pick it, you know, the next level up on the table of contents. I was trying to-
Yeah, and if like just the type 5, you know, trauma code sounds foreign, you need to go back and check and make sure that your patients are classified as that. And, yeah, I mean, there's so many opportunities, you know, when I first got to Grady, there was a lot of activation fee money left on the table, and your managed care folks will, you know, talk to you all day long about where they are in their contract negotiations, and it doesn't matter. Even though you can't recoup that money, you have to show that it's actually a charge before you can actually get money. So it's just like this sort of CMS prospective payment. And it's just as much of a problem to undercharge as it is to overcharge.
And I would think that from a wanting to recoup revenue, I mean, I don't know about y'all, but everyone, our margin is our number one conversation almost every other day. Besides quality and safety, the number one too. So it's important just to understand and make sure that you are recouping, because you're spending the money. I can guarantee you, you are spending the money in readiness to be prepared. And so why not take advantage and understand every ounce of what you can, make sure you're recouping. So a lot of great work being done there. Thank you, Regina and team, for making that happen with the work groups. So just provide any feedback that you can or would like to. On that. What else? Any other questions?
Michelle, can I ask you a
Yes,
question about
please.
their website?
Yes.
Favorite topic, Lori's gonna be. When we transition to Image Trend, what can we expect? Are we gonna have some sort of downtime? And then is there gonna be some communication out to our EMS partners?
Yes,
Okay,
yes to all of that. So Image Trend will actually do the training
okay.
themselves, and then it'll be recorded so you can refer to it or send it to your team or whatever. You'll be the administrator, or you at your facility will be the administrator. You can build your dashboard however you want it to look, you know, whatever works for you. So there's a lot of options that, you know, may want, may not want. So more to come. The Image Trend team came out about 2 weeks ago, and they spent 2 days in the GCC. And what they were building for us was kind of on their standard platform. And once they sat with the team and talked about the needs and what would be, you know, great if you had this, what don't you need, they went back to the drawing board and really are redoing the whole thing. So I think everybody will be pleased with it. It's a little more visually pleasing. I've got some screenshots I can send you if they're kind of what they're working on, their mock-up. But, and a lot of functionality for EMS. It won't be until after June, but they're gonna have an app that can roll out for us at EMS. We can communicate directly with EMS through the app. They can import data into their EPCRs if they're on Image Trend. We can map them when they use the app. So lots of stuff.
So do we have a strategic plan about getting more people engaged to maybe use a newer, more robust product once we get this up and running?
I think that will be the group. It's with DPH, OUMSNT, GHA, just because it's so much more than just the trauma centers. You said there's about 70, 75 more hospitals that are not trauma centers and that utilize it quite a bit. So we want to make sure that we're engaging them as well. I will tell you, through COVID though, you know, when you go and look at the board, people were updating it. Hospitals were updating it pretty regularly when there was an urgent need. And so it's just getting back into that habit. But it's adding value. What's the value add to them? What's the value proposition for them to want to be able to use it? And so I think that's what we have to tap into. And I think for every center, it might be just a little bit different. Right question.
And then I do want to give kudos to Lori. We did ask for reports from the GCC with the closing of Atlanta Medical, and I certainly appreciate the weekly reports of it.
Yeah, the volume has been
They're busy.
busy. Yeah, busy across the board. Very, very busy. Very, very busy. You know, I wanted to share this morning, as they were kicking off, and, you know, I'm a nurse by heart, but I've been an administrator for a long time, and I know I was dealing with fires today. You know, I had to jump up because I had a big issue, and I'm pulling everyone together for a WebEx, you know, at the last minute, all the things that we do. And, you know, I really want, you know, very sincerely, but I want you all to have value in this, right? I don't want it to be, okay, I have to go to the G, you know, I gotta go, this is my hour and a half, let's see here, I gotta be in person. If that's what you want to do, that's fine, right? But I don't think that that's really what everybody really wants to do. I think there's things that we can do here, conversations we can have, relationships that can be built so that you have that phone of friends when something comes up or there's a question. And so I strongly encourage how those develop, particularly if you're still here this evening. Well, this morning, as I was, you know, Dr. Todd and I were talking, you know, I took off my nurse hat and I sat in the room as an administrator. And so two things came up within the first 30, 45 minutes. And he mentioned one of them, as Dr. Bilal was talking, we do have some new beds opening up. We will have the ability to do that. But then he mentioned the mini BAL, the VAP guideline, which we're going to add mini BAL to that. But my administrator's, you know, thought process was, do you have the equipment? You know, so when you come to these meetings and these events, sometimes our staff, our team is so far in the weeds that they can't see the questions up here that we can see because we think differently. And so even when I brought up the beds, it's like, oh my God, I never even thought about that. That's fantastic. Like, absolutely, we have an ACE unit already. We already have an acute care for elderly unit for medical, but what if we did one for surgical? So when you come to these, you know, I think for me, I guess I'm sharing with you my value proposition, why it matters to me when I come to this is because I'm able to take that step back, let the clinical experts do what they do so very well. At the same time, add in my strategic thought process into, okay, how do I support them? Because they're talking about patients, which is why we're all here, right? Fundamentally, it's for our patients. How can I support them as an administrator? So just wanted to share my value proposition as to why, you know, I enjoy coming, even when I wasn't a commission member, I still came because I found value in what we could bring back to our teams. So just wanted to share that a little bit. All right. I don't think the bourbon bar opens until 5. Just kidding. All right, no, I'm not. Not at all. Okay. Anybody else have anything they want to share? Any questions? You know what we didn't do, and that's my fault. We did not do introductions. And I thought about that. And a lot of us know each other because we've been here a couple of times. But let's just quickly go around the room as I tell you, you need to build relationships, right? It's all about relationships. Just do a quick who you are, where you're from, and what you do.
Yes, I'm Angela Geary. I'm the Executive Director of Trauma, Emergency, and Observation Services for the system. And we are now officially a verified level 1 trauma center.
I'm Marty Wynn, CFO of Piedmont Rockdale, Piedmont Walton Hospitals.
Y'all your team did a fantastic presentation this morning.
Yeah.
They really did. And I've worked in a smaller hospital. So what they did was not easy. Like they don't have the resources some of the big centers have. So it's just amazing. It's some really good work.
And more importantly, they got verified during their consultative visit,
Amazing.
which is phenomenal. Phenomenal. Great work.
Mary Ann Nolan, I'm the Administrative Director of Emergency and Critical Care Services at Augusta University Medical Center.
I'm Regina Medeiros, as Liz mentioned, I am a commission member. I'm the chair of the budget subcommittee, so I take bribes for all of the money. Or what bourbon, or something about the bourbon bar, that works too. But I'm the administrative director of our adult level 1 and level 2 trauma center. Peace Trauma.
I'm Victor Kelly, Executive Director of Patient Services at Piedmont Edwards Regional.
You've been on this team with me for quite some time, haven't you? You have.
I'm Judy Nguyen. I'm the Chief Nursing Officer at Hamilton Medical Center.
I'm Dr. Brian Lashman. I'm Executive Vice President and System CMO for the Hamilton Healthcare System.
I'm Tiffany Counter. I'm the Vice President of Rural Health for Adrian Health Board.
Brandon Roberts, the Director of Trauma and Transport in the Transfer Center of Children's Healthcare.
Becky Wagler, Director of Trauma and Emergency Services, Motorcycle and Italy.
And then her chief nursing officer, North Carolina.
Steven Sherlock, I'm Director of Critical Care Services and Respiratory, and I'm here representing our Chief Nursing Officer, Amy Group.
Ralph Castillo, CEO, Morgan Medical Center, Madison, Georgia.
I'm Patrice Walker. I'm the Chief Medical Officer for Atrium Health Madison. I pretty much just do what Dr. Ashley said. The other thing I wanted to, the comment that I wanted to make real quick was, I similarly had sort of an epiphany this morning too, in terms of, things that administrators know are coming down the pipeline that our frontline folks maybe don't know, as part of the presentation this morning, and thinking about what we could do with our geriatric, frailty index or whatever. In June, I know that we're actually getting ready to roll out this huge social determinants of care initiative.
Yes.
So I'm thinking, oh, this is fantastic. We can link those two things together. Now we can identify a super high risk population that, we're always as administrators trying to figure out how do we get the most bang for our buck. There are so many different things we could do, but we only have limited resources. So how do we pick a particular patient population or department or whatever you want to do, and how do we focus those resources to ensure that we're really getting the return on that investment? So, coming to places like this where I can connect things that we're already planning with other things that we maybe have to do or should be doing, that's very valuable.
Yeah, and actually, Dr. Walker, before that point, Joint Commission it started to require the SDOH screening. So what a perfect opportunity. You're right, because I was just thinking I have a meeting on Monday about that. How do we tie those two things together, to make sure that we're accomplishing that. So that's just a great idea. So that's phenomenal. Okay.
Hi, I'm Frances. I run neuro and trauma for Wellstar Health System.
I'm Amy Davis, Chief Nursing Officer.
And I think Amy and Frances were both the two co-chairs for the throughput diversion and everything else that we threw at them for a little bit. So thank you all very much for your time. Just great work there.
David Hoffenberg, I'm Chief Operating Officer at Memorial Health in Stanton. I'm Jeffrey Harden, Chief Nursing Officer at Memorial Health in Vidalia, Georgia.
And Ross Camp, I'm the Chief Operating Officer at Fairview Park in Dublin, Georgia.
I'm not an administrator, but I'm Gabby.
But she's Gabby, she runs the show.
I gotta put a face with the name.
I'm Cindy Hongard, I'm the Event Health Ribbon, and I'm the Director of the ER Trauma.
April Dukes, Chief Nursing Officer, Vice President of Clinical Services at Crisp Regional in Cordova, Georgia.
Jen Tickle, Chief Nursing Officer at Piedmont Clarksville, Georgia.
Paula Buds, Chief Nursing Officer at Piedmont Henry Hospital.
Christopher Riza, Vice President of Trauma Services, covering trauma and births at Dr. Hospital.
Katie Hamilton, Finance Operations Officer with the Georgia Trauma Commission.
You know me. I work for Katie, yeah. What to do when you need money, I ask this lady. 50% of the power couple right here.
I'm Lori Wood. I'm the Vice President of Emergency Management for Grady.
Sheila Van Dunn, Senior Vice President, Chief of Patient Services, Fracture Catholic. And we have our verification survey in June. So that we've been working hard for the last 3 years to get ready, so.
Good luck. I'm sure you guys will do great.
Goodbye.
Hey, Marcus Lindsay, County Executive with Airlac, Georgia, and I maintain our relationships with our hospital partners for North Georgia.
So we might need to have you at our meeting when we have our helipad meeting then.
Absolutely.
Hi, I'm Mike Johnson, Director of Office of EMS and Trauma.
And I say about relationships, and these two ladies may not remember it, but both April and Tiffany, about 15 years ago, we were on a VHA ED council together. I don't know if y'all remember that, but I do remember the connect names. And so while we haven't stayed connected, you do build relationships with folks, and you do have remembrances. So you can call it. It's been a minute. It's like mid 2000s when it all happened. So, anything else anybody would like to bring to the group? 3:43. All right. Well, thank you all very much. Hopefully, y'all are going to stick around for dinner. Socialize a little bit. If not, I think we have our next meeting in April 24th. We are adjourned.